Welcome to the deep dive. We're here to, cut through the noise and get you really well informed fast. Today we're plunging headfirst into something that can be, well, pretty confusing. Medical distinctions, we've got a whole stack of source material here, clinical summaries, diagnostic guides, you name it. Our mission, to pull out those key nuggets of knowledge for you.
Exactly. And it's not just about definitions. We want to get into why these differences matter. We're talking skin conditions, eye emergencies, meds, even ethics. We'll help you see what's crucial in all this info we've gathered.
Okay, let's dive in. First up, skin stuff. Two conditions that sound almost the same. Actinic keratosis, AK, and seborrheic keratosis, SK. We'll start with AK. What is it, and why should we care?
Right, so actinic keratosis, or AK, it's basically an atypical growth of keratinocytes. Those are your main skin cells in the outer layer, the epidermis. And it's mostly caused by, well, too much sun over time.
Okay, sun damage. Makes sense.
But here's the really critical part. It's precancerous. It can turn into squamous cell carcinoma, or SCC.
Okay, precancerous. That's the key takeaway.
Definitely. It usually looks rough, scaly, maybe tan or pinkish. You'll see it on sun-exposed spots, scalp, legs, arms, face. There's a little mnemonic. The ACT and actinic reminds you to act fast because of that cancer risk.
Act fast. Got it. So what do you do about it?
Treatment often involves things like cryotherapy, freezing it off, or maybe a topical cream like Fluorosil 5-FU. That's actually a type of chemotherapy cream that targets those precancerous cells.
Right, so you actively treat it because of the risk. Okay, now what about the other one, seborrheic keratosis, SK? How's that different? Is it also risky?
Great question, because they look and sound similar, but they're worlds apart. SK is benign. Totally benign.
Benign. Okay, so no cancer risk there.
Nope, none at all. It's super common, especially as people get older. It has this very distinct look people say stuck on, like a piece of wax stuck to the skin.
Stuck on, yeah, I think I've seen that.
Probably. They're often brown, tan, or dark. Pretty well defined. You see them on the chest, back, arms, face. And the mnemonic here, the S in seborrheic, can stand for stuck, for that stuck-on look.
S for stuck. Makes sense. So, treatment.
Usually none needed, unless someone wants it gone for cosmetic reasons. Then yeah, cryotherapy is an option, just like with ATs sometimes. But the big picture, AK has that malignant risk, SK doesn't. Knowing the difference means knowing when to worry and when, not to. It's about informed action.
Okay. Moving from skin lesions to rashes. Erythema migrans versus erythema infectiosum. They sound alike. Tell us about erythema migrans first.
Erythema migrans, that's your classic bullseye rash. It expands outwards, and it's linked with early Lyme disease.
Lyme disease, right, the tick thing.
Exactly, caused by the bacterium Borrelia burgdorferi. A little trick. If you flip the last two letters of Lyme, Lyme, you get EN for erythema migrans.
EN for erythema migrans. Clever. Okay, so what's erythema infectiosum then?
Erythema infectiosum, that's better known as fifth disease. It's a very common childhood illness caused by parvovirus B19.
The fifth disease. I remember hearing about that. What does it look like?
The classic sign is the slap cheek rash. Really red cheeks. Then often you get this lacy-looking rash on the arms and legs.
Slap cheek. Okay, any mnemonics for that one?
Yeah, think of 5 fingers, like a hand, giving a gentle slap to the cheek. 5 fingers, fifth disease.
Nice one. Anything else important about fifth disease?
Yes, actually, parvovirus B19, the virus that causes it, can be quite serious for certain people. Specifically, it can trigger something called an aplastic crisis in patients with sickle cell disease. Their body just stops making red blood cells for a bit.
Whoa, okay. That's a really important connection to make. Good to know.
Definitely need to keep those underlying conditions like hemoglobinopathies in mind.
Right. Let's switch gears to the eyes. 2 big emergencies, retinal detachment and acute angle closure glaucoma. Start with retinal detachment. What's the experience like?
Retinal detachment is usually painless vision loss. That's key.
Painless. That seems counterintuitive for an emergency.
It does, but that's often how it presents. People might see flashes of light, a sudden increase in floaters, or describe it like a curtain coming down over their vision.
A curtain? Wow.
Yeah. The mnemonic could be painless pulling curtain. It needs immediate attention, ER and ophthalmologist, right away.
And what would they see in an eye exam?
A key sign is loss of the red reflex when they shine a light in the eye. That normal reddish glow from the back isn't there.
Okay, painless curtain, loss of red reflex, needs immediate referral. What of the other one? Acute angle closure glaucoma. How's that different?
Totally different presentation. Acute angle closure glaucoma, AACG, is typically severe pain. really intense eye pain.
Okay, so pain is the big differentiator here.
Huge differentiator, plus blurred vision, maybe seeing halos around lights. And the eye itself might feel firm if you gently touch it because the pressure inside is way up.
High pressure, firm eye, severe pain. Also an emergency.
Absolutely. Immediate ED or ophthalmology referral, just like detachment. But the immediate treatment also involves getting that intraocular pressure down with specific medications.
And the eye exam findings.
You'd likely see a pupil that's sort of mid-dilated and doesn't react properly to light, and the cornea might look cloudy. So, yeah, both are emergencies needing fast action, but the symptoms, especially pain, and the immediate steps are quite different. Pain isn't always the main signal for urgency in eyes, which is a crucial point.
Definitely. Okay, let's talk sore throats. Mono versus strep. Very common. How do we tell them apart, starting with mono?
Okay, mononucleosis, or mono, caused by the Epstein-Barr virus. You see it a lot in teens and young adults. Spreads through saliva, the kissing disease, right?
Symptoms.
The big ones are major fatigue, like really wiped out, plus fever, sore throat, and importantly, swollen lymph nodes in the back of the neck, posterior cervical lymphadenopathy.
Back of the neck.
And often an enlarged spleen called splenomegaly. Diagnosis is usually a monospot blood test.
In treatment.
Purely supportive. Rest, fluids, maybe some over-the-counter megs for fever or pain. No antibiotics. They won't help a virus. And a really key piece of advice for patients: avoid contact sports. If that spleen is enlarged, a hard hit could rupture it, which is a medical emergency.
Wow, okay, no contact sports. Got it. So mono is viral, back of neck nodes, maybe big spleen, no antibiotics. What about strep throat?
Strep throat, that's bacterial. Group A streptococcus, more common in kids usually.
Bacterial.
Okay, symptoms.
Sore throat, definitely. Fever, pain when swallowing. But here, the swollen lymph nodes are typically in the front of the neck, anterior cervical lymphadenopathy.
Front versus back, that's a good distinction.
Yeah, and you might see swollen tonsils, sometimes with white patches and often little red spots on the roof of the mouth. Palatine petechiae.
Palatine petechiae, okay. Diagnosis and treatment. Diagnosis is usually a rapid strep test, maybe followed by a culture. And because it's bacterial, treatment is antibiotics. Penicillin or amoxicillin are common choices. So you see, knowing the difference matters hugely. Viral versus bacterial, different nodes, different signs like splenomegaly or petechiae, and crucially, antibiotics or no antibiotics. Big implications for care and antibiotic stewardship.
Absolutely. All right, let's tackle some medication mix-ups. TZDs versus thiazide diuretics. Similar names, but different jobs. Tell us about TZDs first.
Right. TZDs, thiazolidinanones, think pioglitazone. These are used for type 2 diabetes. They help improve the body's sensitivity to insulin.
Okay, diabetes meds. Any big warnings?
Yes, a major one. They can cause fluid retention, leading to peripheral edema, swollen ankles and legs, and because of that, they are absolutely contraindicated in patients with severe heart failure, specifically NYHA class 3 or 5E CHF.
Contraindicated in severe heart failure. That's critical.
Definitely. A way to remember, the Z in TZD could stand for zone, like a danger zone for heart failure patients.
Danger zone. Okay, now, thiazide diuretics. Hydrochlorothiazide, chlorthalidone. They sound similar to TZDs. How do they work?
They sound similar, but they do the opposite regarding fluid. Thiazides block sodium and chloride from being reabsorbed in a part of the kidney called the distal tubule. This makes you excrete more salt and water.
So they remove fluid, unlike TZDs, which can cause retention.
Exactly. That's the core difference. They're actually a first-line treatment for high blood pressure, hypertension, and chlorthalidone in particular has data showing it's cardioprotective.
Interesting. Anything to watch out for with thiazides?
Yeah, you need to monitor electrolytes, sodium, potassium levels can drop, while calcium levels might go up. So TZD means fluid retention risk, danger and heart failure. Thiazide means fluid removal, good for blood pressure. Knowing that difference is vital.
Definitely vital. Okay, let's move back to infections, specifically tick-borne illnesses. Rocky Mountain spotted fever, RMSF versus Lyme disease. What ties them together and what sets them apart?
Okay, both RMSF and Lyme are spread by tick bites, and the main treatment for both is usually the antibiotic doxycycline.
Doxycycline for both, generally.
Yeah.
How does RMSF present?
RMSF typically starts with fever, headache, and then a characteristic rash that often appears on the hands and feet, wrists, and ankles are classic spots.
Rash on hands and feet, got it. Any treatment nuances for RMSF?
Yes, and this is important. For RMSF, doxycycline is the recommended treatment for everyone, regardless of age. That includes young children and even pregnant patients.
Everyone gets doxy for Rocky. Easy enough.
Yep, the mnemonic is, with Rocky, they all get doxy.
Okay. Now, Lyme disease. We mentioned the bullseye rash, erythema migrans earlier. What about treatment? Is it always doxy too?
Doxycycline is definitely the preferred treatment for Lyme as well, except in pregnant patients.
Ah, an exception. What do pregnant patients get?
Pregnant patients with Lyme disease should be treated with amoxicillin instead.
Amoxicillin for pregnant Lyme patients. What about young kids with Lyme?
Interestingly, current guidelines suggest young children with Lyme can still receive doxycycline similar to adults. It used to be avoided, but the recommendations have evolved based on newer data showing it's generally safe for short courses, and the risks of untreated Lyme are significant.
So the main exception is pregnancy.
Exactly. So picture this. A pregnant camper goes hiking, gets a tick bite, develops that bullseye rash. Diagnosis, Lyme disease. Treatment, amoxicillin, not doxycycline.
That's a really practical, important distinction, and a good reminder about tick prevention.
Absolutely. Prevention is key, but knowing these treatment nuances is critical if someone does get sick.
Okay, let's touch on a couple of common herbal supplements. St. John's wort and kava kava. What's the deal with St. John's wort?
St. John's wort is often used by people for depression. It can have some effect.
But for the sense of butt coming.
Yes, a big but. The major issue is drug interactions. It interacts with a lot of medications. The most dangerous one is probably with other serotonergic drugs like SSRI, antidepressants, think sertraline, fluoxetine. You risk causing serotonin syndrome. That can be serious. Symptoms include things like confusion, headache, nausea, vomiting, diarrhea, maybe dilated pupils, fast heart rate, sweating.
Yikes. So if someone's on an SSRI?
They absolutely should not be taking St. John's wort. If you find out a patient is on both, they need to stop the St. John's wort immediately and be monitored.
Crucial safety point. Okay, what about kava kava?
Kava kava is typically used for anxiety relief.
Anxiety. Any quick way to remember that?
Maybe imagine someone who's anxious sort of stuttering, kava, kava, helps link it to anxiety.
Okay, I can see that.
The big takeaway with both of these, though, is how important it is during medication reconciliation reviewing all meds to ask specifically about herbs and supplements. They're not always harmless, especially St. John's wort.
Excellent point. Natural doesn't always mean safe, especially with other meds. Okay, knee injuries. ACL tear versus meniscal tear. How can we tell the difference? Let's start with the ACL.
Okay, ACL, anterior cruciate ligament tear, often happens with a sudden stop, pivot, or change in direction. Sports injury, classic.
What does the person experience?
The hallmark is often an audible pop sound at the moment of injury.
A pop.
Followed by pretty immediate swelling and significant pain. Usually they can't continue playing or whatever activity they were doing.
Pop, immediate swelling, can't continue.
Yeah.
Got it. How do you test for it?
There are specific orthopedic tests. The Lachman test is considered more specific, and there's also the anterior drawer test. So imagine a soccer player pivots sharply, hears that pop, knee swells up fast. A positive Lachman test pretty much confirms an ACL tear.
Okay, that paints a clear picture. How does a meniscal tear differ?
Meniscal tears usually happen from a twisting injury while the foot is planted bearing weight.
Twisting. And the symptoms?
Swelling often comes on more slowly, maybe hours later or the next day, not immediately like the ACL.
Delayed swelling, okay.
And patients often report a feeling of catching, locking, or the knee giving way. Sometimes they can actually continue their activity initially, unlike with most ACL tears.
Catching or locking. And they might be able to keep going.
Yep, different tests. The McMurray test and the Apley-Grind test are common for suspected meniscal tears. So the key differences are really that immediate versus delayed swelling, the pop with the ACL, and the locking catching sensation, often associated with meniscal tears. If someone has persistent knee locking after a twist, gotta think meniscus and get it checked out.
Great distinctions. Let's move down the leg to circulation problems. CVI versus PAID. Chronic venous insufficiency first.
Right, CVI. This is a problem with the veins getting blood back up to the heart from the legs.
So what does that look like?
You typically see warm, swollen, edematous legs. Often varicose veins are visible. The skin might be irritated, maybe brownish discoloration, that's stasis dermatitis. Patients might complain of a dull ache or heaviness. Wounds, if they occur, are often irregularly shaped, maybe weeping, usually around the ankles. The mnemonic veins can help remember some features: varicose veins, edema, irregular wounds, normal pulses usually, stasis dermatitis.
Veins, nice. How do you manage CVI?
Management focuses on helping that venous return. So compression stockings or wraps are key. elevating the legs, and exercise like calf pumps to push blood upwards. If there's a wound with lots of drainage, high compression dressings are used.
Okay, so CVI is warm, swollen, involves getting blood back up. What about PAD, peripheral arterial disease?
PAD is the opposite problem. It's about arteries not getting enough oxygenated blood down to the extremities.
Arterial flow issue, how does that present?
The legs and feet often feel cool to the touch. The skin might look shiny, thin, and hairless. Peripheral pulses, like in the foot, are usually diminished or even absent.
Cool, shiny skin, weak pulses. Any specific kind of pain?
Yes, the hallmark symptom is intermittent claudication.
Claudication.
Yeah, it's muscle pain, usually in the calf, that comes on with activity like walking a certain distance, and gets better quickly with rest.
Pain with walking, better with rest. Classic.
Exactly. It's because the narrowed arteries can't supply enough oxygenated blood when the muscles are working harder. Any ulcers tend to be more punched out, often on the toes or pressure points, and are typically quite painful unless there's also nerve damage. So, big picture. CVI, warm, swollen legs, venous return issue, PAD, cool, pale legs, diminished pulses, arterial supply issue, claudication, very different causes and management.
Very clear distinction. Okay, let's shift completely now to ethics. Fidelity versus veracity. What do these principles mean in, say, a healthcare setting? Let's start with fidelity.
Fidelity is about being faithful, loyal, keeping your promises. It's about demonstrating reliability to patients.
Can you give an example?
Sure. A nurse tells a patient, I'll be back with your pain medication in 10 minutes. If the nurse actually comes back in 10 minutes with the medication, that's demonstrating fidelity. It builds trust.
Keeping your word.
Yes.
Simple but powerful. Okay, what about veracity?
Veracity is the principle of truth-telling. It's the obligation to be honest and truthful with patients, even when the news is difficult.
So, honesty, even when it's hard. Example.
A classic example is delivering a terminal diagnosis. Doing so with accuracy, clarity, and compassion embodies veracity. Not hiding the truth, but communicating it appropriately. Both fidelity and veracity are absolutely fundamental to building and maintaining that crucial trust relationship between a professional and a patient.
Absolutely foundational. Okay, let's tackle pregnancy signs. Presumptive, probable, and positive. Walk us through them, starting with presumptive.
Okay, presumptive signs. These are the subjective things the patient experiences and reports. They make you presume or assume pregnancy, but they could be caused by other things too.
Like what?
Nausea and vomiting, morning sickness, right? Missing a period, amenorrhea, breast tenderness, feeling tired, maybe feeling those first little flutters of movement called quickening. These are all presumptive.
Okay, subjective hints. What about probable signs? What makes them probable?
Probable signs are more objective findings that an examiner might notice, making pregnancy more likely, more probable.
Objective findings.
Yeah.
Examples.
A positive HCG pregnancy test, urine or blood, is a big one.
Wait, isn't a positive test definitive?
Almost, but technically HCG can be elevated for other reasons, though it's rare, so it's still considered probable. Other probable signs include physical changes the examiner finds, like Hagar, sign softening of the lower uterus, Chadwick sign, that bluish color of the cervix, and Goodell, sign softening of the cervix itself.
HCG, Hagar, Chadwick, Goodell. Any way to remember those?
Well, you can think HCG for the test and the signs, Hagar, Chadwick, Goodell. And for Goodell sign, think good and soft. The cervix gets softer for delivery.
Good and soft. Okay. So presumptive is subjective. Probable is objective, but not 100% certain. What makes a sign positive?
Positive signs are the ones that offer direct, undeniable proof of pregnancy. There's no other explanation.
The definitive proof, what are they?
There are basically three. Think PUF, palpation of fetal movement by the examiner, not just the mother feeling it, ultrasound visualization of the fetus, and hearing fetal heart tones.
PUF, palpation, ultrasound, fetal heart tones. Got it.
If you have one of those, it's confirmed. Understanding these categories really helps you think through the diagnostic process, moving from suspicion to certainty.
Definitely a useful framework. Let's go back to the skin for a moment. Two more lichen conditions. Lichen simplex chronicus versus lichen sclerosis. What's lichen simplex chronicus about?
Lichen simplex chronicus, the name gives a clue. Chronicus implies it's chronic. It results from a persistent itch-scratch cycle.
Itch-scratch cycle. So something else starts the itching.
Exactly. Often there's an underlying condition like eczema, atopic dermatitis, or even just dry skin or stress that starts the itch. Then the person keeps scratching or rubbing the area, and the skin responds by thickening, becoming leathery or rubbery in texture.
Leathery skin from scratching. How's it treated?
You need to break that cycle. So moisturizers, maybe antihistamines to reduce itching, and often low-potency topical steroids to calm the inflammation.
Okay. Now, lichen sclerosis. Sounds similar, but what's different here?
Very different. Lichen sclerosis is most often found in the genital and anal areas.
Genital area. Okay. Who gets it?
It can affect anyone, but there's a higher risk group. Postmenopausal women.
Postmenopausal women.
Yeah.
Symptoms.
It can cause significant discomfort, painful intercourse, tearing, bleeding. The skin often takes on a characteristic white, thin, crinkly appearance on the vulva.
White, thin skin. Sounds uncomfortable. Treatment.
Treatment usually involves high-potency topical steroids like clobetasol. This is actually an exception to the usual rule of avoiding strong steroids on genital skin because it's needed to control the inflammation here.
High-potency steroids. Okay. Anything else crucial about lichen sclerosis?
Yes, a very important point. It carries an increased risk of developing squamous cell carcinoma in the affected area.
Increased cancer risk. Wow.
Yeah. So the S in sclerosis can help you remember the risk of squamous cell carcinoma, requires long-term monitoring. So lichen simplex chronicus is about an itch-scratch cycle, often on limbs, leading to thick skin. Lichen sclerosis is typically genital, causes thin white skin, needs strong steroids, and carries a cancer risk. Big differences.
Huge differences, especially that cancer risk. Okay, let's listen to the heart. S3 versus S4 heart sounds. What's the story with S3?
The S3 heart sound, sometimes called a ventricular gallop, is often associated with conditions involving increased fluid volume or flow, like heart failure or pregnancy.
Heart failure and pregnancy. Makes sense with extra fluid.
Right. But here's the thing. S3 can also be a completely normal finding in young, healthy people, especially athletes.
Normal in young people. Okay, how to remember the associations.
Think heart failure and pregnancy both have 3 syllables, S3.
3 syllables for S3. Nice. What about S4?
The S4 sound in atrial gallop is typically heard when the ventricle is stiff and non-compliant. This is often associated with conditions like long-standing uncontrolled hypertension or left ventricular hypertrophy, thickening of the heart muscle.
Hypertension and hypertrophy, also conditions we worry about.
Definitely. But like S3, S4 can sometimes be a normal finding, particularly in older adults without other heart disease signs.
Normal in older adults sometimes. Memory trick for S4.
Yep. Hypertension and hypertrophy both have 4 syllables.
4 syllables for S4. Perfect.
And just as a quick bonus, the normal S2 sound, the second heart sound, is caused by the closing of the aortic and pulmonic valves, the semilunar valves. So hearing an S3 or S4 means you need to consider the context. Is this a young athlete, maybe normal S3, or someone with signs of heart failure, pathological S3? Is it an older adult, maybe normal S4, or someone with uncontrolled high blood pressure, pathological S4?
Context is everything. Okay, let's look at the hands again, specifically signs of osteoarthritis. Heberden versus Bouchard nodes. Where do we find Heberden nodes?
Heberden nodes are those bony bumps you see on the distal interphalangeal joints, the DIP joints. That's the joint closest to the fingertips.
Dicky joints. Fingertips, How to remember that?
The fun mnemonic is, the dip is in the den, DIP joint, Heberden.
The dip is in the den. I like it. Okay, what about Bouchard nodes?
Bouchard nodes are similar bony bumps, but they're found on the proximal interphalangeal joints, the PIP joints. That's the middle joint of the finger, just below the DIP joint.
PIP joints, middle joint. Are they also just in osteoarthritis?
Primarily seen in osteoarthritis, yes, but you can sometimes see them in rheumatoid arthritis as well.
Okay, so maybe associated with both sometimes.
Right, so a mnemonic could be the B in Bouchard stands for both osteoarthritis and sometimes RA, and they're found on the joint beneath the Heberden node.
B for both, beneath, helps place them. Knowing these helps pinpoint the type of arthritis.
Exactly. They're classic signs, especially Heberden nodes for OA. Helps you visualize what's happening in those joints.
Great visual distinctions. Okay, nearly there. Let's do a quick spotlight on the big 3 skin cancers, BCC, SCC, and melanoma. How do we spot basal cell carcinoma, BCC?
BCC, basal cell carcinoma, is the #1 most common skin cancer by far.
Most common. What's its look?
Think pearly, shiny, maybe waxy, often raised. It might look like a small bump that's sort of translucent or pearly white.
Pearly and shiny, like a pearl earring, maybe?
Exactly like that. And sometimes you can see tiny blood vessels on the surface. Those are called telangiectasias.
Pearly, maybe with tiny vessels.
Yeah.
Okay, squamous cell carcinoma, SCC.
SCC often looks different. Think rough, scaly, maybe ulcerated. It often bleeds easily, like a scab that just won't heal properly.
Ulcerated, bleeds easily.
Didn't we say this can come from something else?
Yes. Good recall. SCC often develops from a pre-existing actinic keratosis, that precancerous lesion we talked about first.
Closing the loop. Okay. And melanoma.
Malignant melanoma.
Okay.
Well, that's the least common of the three, but it's the most deadly. We often use the ABCDEs to screen for it, but its appearance can vary widely. That's a whole topic in itself. But knowing the classic look of BCC, pearly shiny, and SCC, ulcerated scaly bleeding, often from AK, is really key for early detection of those common types.
Absolutely key. Okay, last section. Let's do a rapid-fire round of alternative names, knowing these can be super helpful. Ready?
Let's do it. Enterobiasis.
Pinworms.
Correct. Measles.
Rubiola. Both have one L.
Got it. Sty.
Or hordeolum, because a hordeolum hurts.
Nice mnemonic. Swimmer's ear.
Otitis externa. Right. Cervical spine instability, especially in Down syndrome.
Melanoaxial instability.
Perfect. Last one, giant cell arteritis.
Temporal arteritis.
Excellent. You see how knowing both names is crucial? Different sources, different doctors might use different terms for the exact same thing.
Absolutely.
Yeah.
Wow, okay, we have covered an incredible amount of ground today, from tiny skin bumps to major emergencies, medication safety, ethics, heart sounds. It's a lot. But hopefully, this deep dive gives you that shortcut, that ability to quickly grasp these important distinctions that can sometimes be really confusing.
I really hope so. Because, knowledge is one thing, but understanding why it matters, seeing those connections and distinctions, that aha moment, that's what really empowers you. It helps you make sense of complex info and ask better questions.
Couldn't agree more. So here's a final thought for you, the listener, to chew on as we wrap up. Think about how getting a handle on these kinds of distinctions, noticing the subtle differences, understanding the why behind them, how might that change how you approach and assess complex information? Not just in medicine, but in any field you encounter. Keep that curiosity sharp. And definitely let us know what other topics you want us to tackle in future deep dives. We love digging into this stuff and pulling out those essential insights with you. Thanks for joining us.